All right, everyone, welcome back to another episode of RetFix and Chill. We're here in Stockholm for ASRS this year, and we are doing our first live recording. I'm Sarwar Zahid from New York City. I have here with me our usual suspect, Nitish Mehta from NYU, and our special guest today, also from NYU, Yasha Modi. Yasha, welcome.
Yeah, thanks so much. Really cool to be part of the first live episode, and this is an awesome town to explore it in.
Yeah, it's great. It's been a great meeting. Nitish, you want to kick us off?
Yeah, so we've been doing a little bit of work discussing different techniques for macular hole repair. You had shared with us that you had an interesting technique that we wanted to go over. You want to start by sharing your case with us, and we can go from there?
Yeah, absolutely. So this is the sort of case that I think my fellows all love. 62 years old, pseudophakic, stage 3 macular hole, has had decreased vision for 1 year. So that's a little bit uncommon. The vision's 2200, and what we're getting at is sort of about a moderate size 400 micron hole with the hyaloid down at the optic nerve. And at this point, I opted to do a vitrectomy, ILM peel, 24% SF6 gas. Would you guys do anything different?
I like it. I think that's the great initial surgery of choice. I mean, just looking at the OCT alone, a couple things do put me at pause. There's a little bit of OCT shine through in the center, which tells me there's a bit of chronicity. Vision's not great, and you said she's been open for potentially a year.
Yeah.
So those are kind of things that I think of that might decrease my initial surgical success. But how do you do your standard peel?
Yeah, so basically it's maybe about 2.5 disc diameters, like 360 degrees around the hole.
Okay.
Yeah. Start a flap almost always inferiorly. Try to avoid starting a flap in the peripapillary bundle. I know some individuals try to sort of protect the ILM in the peripapillary bundle, but a couple of times I've actually done cases where I've left it, and then when I come back for those holes that have been persistently open, which is fortunately a very rare occasion, when I do peel that residual ILM, it's amazing how much traction it exerts on the hole. And so I basically do a 360 peel around the hole.
What was the rationale for people to preserve the peripapillary bundle there?
Just the idea that you're not diminishing their visual field. Remember, you're removing the foot plates of Mueller cells when you're peeling ILM. So it's an intrinsically destructive procedure, even in the hands of the slickest surgeons. And so the goal is to really try and prevent progression of nerve fiber layer atrophy, which can then associate with GC IPL atrophy.
Any favorite tools as you're going about moving things around? Do you like the loops? Do you like particular forceps, or what works well in your hands?
Yeah, so for epiretinal membrane peeling, I do classic pinch and peel technique, and I start on the epiretinal membrane. There's almost always a handle. So for my fellows, they know that they have to bring in the cube, the volumetric cube, the video, and we talk about places to start based on easy accessibility. Essentially looking for places where the epiretinal membrane is split and away from the ILM, so a safety margin for peeling. In obviously ILM peeling, there is no safety margin. It's intrinsic to the retina. And so what we're looking at is essentially starting with a more blunt object. So I use the flex loop, or the equivalent would be like a Tano scraper, and we're gently lifting an inferior flap. And you can actually lift pretty large flaps and then make the ILM peeling quite a bit easier. Yeah. So start with flex loop, move on to ILM forceps.
Yeah.
Do you guys do about the same, or you pinch and peelers? Sarah, what's your strategy?
I am a flex loop guy. I also do the same thing. I look at the OCT right before, and if there's a nice separation, sometimes with some contraction, sometimes you can have some separation of the ILM too. If I feel there's a safe space for me to start, I'll use an ILM forcep. But I love the flex loop because you can expand it and have a broader, more flexible surface. I feel like it's gentler. I never see any of my pinch and peel divots on my OCT, so I like to be as atraumatic as possible, but perhaps I have less finesse with my pinch and peel, but looking at the OCT, key tip, because then you know where it's safe to grab.
Yeah, I think you taught me when I was a resident to just try to gently press next to the vessels, and that's where it's most easy to split, and just carry that along.
Intrinsic weakness, I think you nailed it, right? There's an intrinsic weakness where the ILM inserts by the vessels. So starting at the sort of adventitial plane of where the vessels are is a very easy place with the flex loop. Now, that's certainly not where I would start if I was pinch and peeling, because then you can have iatrogenic injury to the vessel. Right. And remember, these are kind of arteries, so you can have a kind of a big bleed. So I certainly wouldn't do that.
So that was a great overview of just your standard peel. So tell us what happened next.
Okay, so I ended up doing 24% SF6 gas, and I regret it. This is the patient, comes back 2.5 weeks later, and now we have this sort of awful configuration of a flat open hole. So we don't have that sort of ski margin or ski slope edges of the macular hole, which I think we all love to see, but rather the flat open hole, which is a considerably harder hole to close. So at this window of time, first of all, this is always a hard conversation to have with patients. You say that we have a 90% success rate with macular hole closure, and now you have to tell them that they fell into the 10% alternative one. And now I think actually probably those numbers are higher, right? Would you say you have a 10% failure in macular hole surgery?
It depends on how aggressive I am with my macular holes. I mean, the more chronic holes I add on, it's definitely a higher number. I love this case because I literally had the same thing happen to me 2 weeks ago, same configuration, SF6 gas, and it looks exactly like that. So I'm facing this right now. I am redoing this case, so this hits home.
Yeah, and Nitish, what do you think?
Yeah, I tell patients that if I can catch you within 3 months of your initial presentation, you have almost, I would say, like a 90% chance of one, closure, and two, possibly achieving 20/40 vision or better at the end of the surgery. Beyond 3 months, I start to notice a very acute drop off in both final visual acuity and hole closure. And we have to remember, it's all about the vision, right? You know, we've learned a lot of techniques and we've discussed a lot of things on this podcast and as a society in general about anatomic closure. But vision is really what matters at the end of the day.
Yep. Yeah, and somebody who's had a hole open for a year is naturally going to be limited. So undoubtedly, when we start thinking about surgery, we're having that conversation up front that all I can do, I'm just what I call myself the wallpaper guy. I can just sort of put the wallpaper back on the retina when it's detached, and all I can do is try to close that macular hole. But ultimately, how the vision recovers is a feature based on age and chronicity as the two main drivers. Right. And so this person obviously has a couple of sort of poor prognostic factors in the sense that they're sort of late middle age and the fact that they've had a hole open for about a year. So, Sarwar, you had this exact same case. Now you're dealing with this, you have a great time in Stockholm, you go home. What's going to be your approach to kind of repairing this?
Great question. I've been thinking about this. So for my case, I did a not as wide peel. It was about a 400 micron hole, which to me is a small hole. But as you said, Nitish, the chronicity makes a big difference. This is a hole that's a year old. So my plan is to widen the peel, but I don't think that'll be enough. Sometimes there's some, with chronic holes, there's some rigidity of the outer retina. We were talking about this a little bit earlier. So I like to try induced macular detachment. That's what I'm planning on doing in this case, and it's a great technique. My anatomic outcomes have been great, but the visual outcomes have been less than stellar.
Less than stellar. Okay, and why do you think that's the case? Do you feel like that's like something that where you limit the vision based on the technique that you're employing, or is it because you're intrinsically limited based on the anatomy that you started with?
I think it's a combination because I think the chronicity definitely doesn't help. In addition to that, the induced macular detachment is a traumatic process. So I think there's a healing process that has to occur from that. It's sort of like a lot of ERMs and chronic holes. You do get ongoing improvement. And a lot of these patients where I've done macular detachment, they're still 2400, but they can get to 2100, 2150, but the improvements are not as great as a 2040 improvement, as you mentioned earlier.
Yeah. Also, we have to think about what our technique is actually doing to the eye, right? So the first thing is removing the vitreous, removing AP traction. The second part is removing the ILM, which is removing sort of tangential traction. And if those two fail, where's the next step? And I think that's where induced macular detachment actually provides an additional benefit from sort of a pathophysiological standpoint, essentially because you've got those edges of the hole where the outer retina and the RPE aren't mobile enough. And so now if you release that connection, you release that chronic tension, there might be a better chance that they'll fall into the right place. Do you agree with that?
Yeah, absolutely. And I sort of love the way that you're conceptually thinking about this, right? Because ultimately, when I'm sort of fellows in the OR, I always sort of talk about a bilamellar structure. You have an inner retina and you have an outer retina. And, you go to VBS, you go to all these great meetings that teach you a lot about surgery. And I sort of think what we should try to do is try to bucket it into conceptual strategies. So we talk about ILM flaps. That could be either sort of an inverted flap, a free flap. We could talk about putting things on the hole, AMT. We can do even blood in the hole. We can do retinal transplants, and we can do ILM peeling. But it's important to realize all of those are fundamentally just addressing the inner retina. So, and certainly they all contribute to increased centripetal migration of the retina and allow for whole closure. But we're still forgetting about the other 50% of the retina. So when I think about sort of how we alter forces acting on the retina as a whole, I sort of say, well, the sort of first approach is always do inner retina. It's easiest, it's safest, but you can also consider outer retina. So actually, Ephraim Mandelkorn, who's out of Canada, talks a lot about what's called macular hydrodissection. He essentially uses a reflex cannula, and what he's doing is he's getting really close to the hole, and he's actually sort of pushing on the reflex. Have you ever used the reflex?
Yes.
Yeah, and he's actually sort of manually sort of pushing fluid in and trying to dissect off basically the retina, specifically the interdigitation zone from the RPE, and then sort of creates a localized detachment. My major concern with that technique is I'm not as skilled as Ephraim. And so I worry about touching down on the RPE. So for me, just sort of like kind of similar to the approach that you like to do, I also like to do a macular detachment. And you can do that with a sort of a 38 gauge cannula, 41 gauge internal diameter. And you could start it anywhere away from the hole and then sort of propagate that towards the hole. And I love it because, yeah, you're going to get these areas where you're going to touch down on the RPE where you're starting it, but it could be a ways away from the macular hole. So that's the rationale for why I do it, because obviously ILM peeling, it's not that difficult, but when we start thinking about these other techniques, bringing a free ILM flap, have you done free ILM flap?
I've tried, but I've always failed because I always lose the flap.
You lose the flap.
It's
Yeah.
too free.
Yeah, it's really thin,
Yeah.
and the ability it curls
floats
over.
around and,
Yeah, and so there's some great techniques where people have described putting like viscoelastic over the hole and then sort of putting it on over as a way to kind of get it to adhere. And I think that's a reasonable strategy. But even then, just the ability to go and actually do a free flap and bring it over to the hole and not lose its orientation is a very, very difficult procedure.
Yeah.
So.
Yeah, I agree. What about pulling in the AMT? Where does that sort of fit into your strategy?
I think that kind of goes to a point that we had earlier, which is that there's no study to date, even in just sort of case reports or case studies, where the vision has improved. Mm-hmm. And I wonder if what we are doing is we are actually sort of making a scaffold, but sort of preventing photoreceptor migration to the center of the hole. Mm-hmm. So I do worry a little bit that we're making the anatomy better, but we're going to rate limit ourselves by vision. Okay. So for me, for amniotic membrane, while I think it's super cool looking, and it's a really great technique to learn, I think, Nitish, you've done a couple, right?
Yeah, I enjoyed on a very chronic case where my goal is closure more than vision. Let's say the patient has bad PVR and I'm worried about further contraction, I'm worried about macular detachment, or they're a high myope and I'm worried that could be a route for detachment, and I need to get this hole closed. It's large. I think it has a role there.
Yeah.
But that would be the highest tier, right? The early tier we talked about. This middle ground is what you're going to show us, but then that final tier is maybe when those actual patches make sense.
Yeah, exactly. And with that technique, I think especially when you have the persistent macular hole detachment, that's where I sort of think the AMT makes a lot of sense, especially because in the United States, we don't have ability to do macular buckling. Right. Some of our Canadian colleagues and our European colleagues have showed all these beautiful videos of putting on a macular buckle. It makes perfect sense to address the myopic macular hole with associated detachment, and yet we don't have access to it.
Yeah.
This was a surgery that I did. You could sort of see the extent of the ILM peel. So it's not a small ILM peel. And, you just sort of do a standard 3-port pars plana vitrectomy. I'm using the Med1 cannula. It's a 38 gauge cannula. And you could see, most importantly, it's important to realize this is connected to the VFC. Mm-hmm. And the infusion pressure is somewhere between 10 and 12 millimeters of mercury. Mm-hmm. So it's actually controlled by my foot pedal. Yeah. And I've actually had BSS in the VFC cannula. And I test it out of the eye. And really what I want is just a dribble of fluid.
With a little extension tubing?
Well, yeah, just exactly like you're just putting in oil in the eye. That's effectively what I'm using.
Are you actually holding the VFC cannula in one hand with the Med1 on it?
That's
directly?
Exactly right.
Okay, because I've done it where you take the VFC cannula and then use some anesthesia tubing, and then you all just have the 38 cannula in your hand. If you're not comfortable holding a large cannula, then you can actually just hold the tip of it.
I feel like we put in oil enough into the eye that we got kind of comfortable with that. Like the phaco probe that we learned with in residency is also a big, heavy probe. And yet somehow we managed to get comfortable with that in our hands. I like this because this has perfect control. It's connected to, your vitrectomy machine, the Constellation in this case, and it allows for really, really accurate sort of delivery of fluid without too much force. So I love the fact that I have full control of this technique. I'm not reliant on a fellow pushing fluid in. And I worry that if you're using too much force that you're going to cause more damage to the RP. So I really would, for those who are trying this technique, you can certainly do this solo. You don't need to have an assistant as a result.
Great.
So you can also get air in, by the way. Have you noticed that in the surgical video, I showed you my very first video of this. And the reason why is because I wanted the audience to kind of get a general sense as to what it's like if you were to do this for the very first time.
That's the point of this conversation, yeah.
Yeah, and I got air in, and I was wondering, like, what would I do if I got air in? And ultimately, I was sort of sitting there after I had got the air into the eye, and I remember this really awesome paper by Tamer Mahmood and one of his fellows that they had accidentally gotten air in a subretinal TPA case to sort of displace subretinal hemorrhage. And what actually Dr. Mahmood did with his fellow was something that was really, really clever. They used the buoyant force of the bubble as a way to then come up with like upright positioning to then displace the hemorrhage inferiorly. And because I had read that paper maybe about 6 months, a year before I did this technique, I felt very, very comfortable having subretinal air and realizing this is only going to allow for further dissection of the retina away from the RP.
Do you feel that there might be a threshold at once that maybe too much air? I mean, is there something...
I don't actively try to put air in. I think, it goes to show you that when you are first doing a surgery, there are always going to be variables that you don't anticipate. And you have to kind of be able to sort of adjust in real time. And sometimes that's where innovation came up, like in the example that I told you about with Tamer. And I think it's okay. I think that we have to be okay with the unexpected in vitreoretinal surgery. And then we have to go and sit there and say, like, how do we think through the physics? What are the vector forces of what we have just done? And how can we use that potentially to our advantage?
Yeah, the entropy is constant, right? That's the one thing we know, that everything will be unpredictable. Well, you mentioned about using the VFC cannula. I mean, it's hard to not get bubbles. I mean, I usually just take the 50cc cannula and stick it into a cup of BSS. But what you were mentioning at this time, yeah, it's a little bit bulky, but connecting this cannula and holding it closer to the eye allows pretty exquisite control when you're close to the retina. The other thing that you mentioned 10 to 12. I've tried 10 to 12, and some of these chronic holes, I've had to increase it to 15 to 18, which, I was a little nervous about when I first did it. But in some of these rigid retinas, you need a slightly higher pressure, at least in the beginning, and then you can bring it back down.
So for those who haven't had experience with subretinal surgery, what are you looking at visually? Are you looking for the tip of the cannula to sort of disappear into the retina? Are you just up against it till you feel close enough? Like, how do you describe that process of getting into the subretinal space?
Yeah. So Sarah, what do you do?
So, two things. I mean, I think, as I get closer to the retina, I start engaging the VFC extrusion pedal. And you can use the shadow, but I'm not as good at using the shadow. It's just something I am not as good at when I'm doing subretinal surgery. But if you have a steady flow, as you get close to the retina, you do see a gentle divot on the retina. Having the ILM peeled is super helpful. The nice thing is, because once the ILM is peeled, you get nice transference of that fluid in the subretinal space. And once you see that tiny little bleb, it's kind of hard to see the divot sometimes, depending on sometimes in a myopic eye, it's really hard to see that. But if you go in towards the retina while engaging your foot pedal at 10 to 12 millimeters of mercury, you'll get a nice little bleb, and then in the space. And then the nice thing is you have that nice little bleb, and you can more safely be a little bit more aggressive at that point, because you have that bleb, you have that separation from the RPE, and then you just propagate it in the direction that you want. The hard part is sometimes the fluid doesn't go in the direction that you want it to, and then you have to redirect the forces, turn your cannula, and sometimes the retina doesn't behave though.
Yeah, I think your advice is spot on. So a few real critical tips. One, I love the fact that you're engaging right before you touch down on the retina. And it's important to realize just the pure physics of this is fluid is going to go to the path of least resistance. When you are first hitting the pedal, it's naturally going to go into your BSS-filled vitreous cavity. The moment you sort of touch down on the retina, you get this sort of dimpling effect. And now, all of a sudden, the fluid's going to go and start dissecting through the plexiform layers, because that's the second point of least resistance. And actually, that's been shown on intraoperative OCT, that you actually get that dissection and a lot of fluid accumulating within the outer plexiform layer. We know that from subretinal surgery, especially with gene therapy. And then finally, as you sort of push down and you get that dimpling effect, you enter into the subretinal space. Now remember, this is a potential space, the same way the plexiform layers are potential spaces. And once you're there, then the bleb just starts developing quite rapidly. And the critical thing, our tendency is when something is changing quickly in the eye, our natural tendency as surgeons is to probably want to pull back just a little bit. And that is where you will lose propagation of the bleb. So the key is really to sort of sit there and say, I know that I'm going to start getting this large bleb, and I'm going to be okay with that, because that's exactly the intended effect. I think a couple times when I first started, I was so excited and happy to get the bleb that I pulled back a little bit, and then I realized I was in the wrong space. Has that happened to you?
Yeah, I mean, the first time I did this, I was like, oh my God, I got a subretinal bleb. But then the nice thing is you have the bleb and you can be a bit more aggressive at that second pass. But yeah, the instinct is definitely to pull back out into the vitreous space.
Yeah. And this is different than submacular hemorrhage surgery, because that potential space has already been opened by the neovascular blood and fluid. Yeah. So we're creating it here, so that makes it a little bit trickier. Are you doing 1 bleb, 2, 3? How do you place them?
So to Star Wars' point, I think he nailed it. Is that remember, you're putting fluid into the path of least resistance, but the directionality of that path cannot be determined a priori, right? So you cannot know which way the bleb is going to propagate. So if you sort of think about a bowl where the fovea is at the center of the bowl, I try to essentially put blebs around the edges of the bowl. So I tend to always start inferiorly, because it's ergonomically the easiest place to do it. And remember, the retina is sort of coming up at you. And so therefore, when you're piercing through, it's the most perpendicular angle that you're going to get. Now, when you're doing it superiorly, you're not perpendicular, but yet you can still make adequate blebs. And so I tend to do one probably inferior temporal, and then start probably superior temporal and superior nasal. And that's typically enough to allow for propagation. Now, one thing is that if you do pull back out of the bleb, it's really hard to propagate within the exact same bleb, because now you actually have a way out for fluid to come, which is through the path of your cannula. So it's essentially what I consider a one and done technique, which is that once you start that bleb, you're there in that space until the conclusion of the bleb, which is why patience is really, really important. Once I've made that bleb, if I haven't got it propagated to the hole, then I have to move to another bleb. Now let's go and say you have these 3 blebs, you're sort of not around the edges of the hole. Well, you can do something, which is that essentially after surgery, what I do is I do a full air fluid exchange, wait until that fluid from the vitreous space repopulates. Then I do another sort of aspiration, make sure that it's like as dry as I possibly can. Then you have all of these blebs of subretinal fluid that will naturally coalesce. And so I keep them on their back for about 30 minutes in recovery, and then I roll them over to face down. So that way, if I haven't got the dissection intraoperatively, I'm likely to get it just by the fluid naturally sort of pooling there.
And then the next step, tamponade agent, influenced at all by this surgery or not?
For me, it's always going to be C3F8 at this point. I think by the time you get to this level of macular hole surgery, we're talking about some of the more difficult to close holes. We are in the probably less than 2% of cases that this is applicable to. And so I think to maximize success, we want a long-acting gas bubble. Would you do anything other than C3F8 at this window of time?
C3F8 hands down. This is a chronic hole at this point and a failed first surgery. So this is a C3F8 case for me as well.
Yeah, I agree.
Yeah, and I would say to Nitish, I think you were kind of bringing this up without trying to throw me under the bus, and I really appreciate that. My major mistake was not using C3F8 in the first case. And my general sense is that I probably would have succeeded if I used C3F8. And now I love your point of chronicity of the hole, and I'm always trying to really pinpoint down the timing in which they may have noticed the difference. And if it is longer than 3 months, I almost exclusively use C3F8.
So just to go over again, the reason that to use a longer or shorter acting is you're giving the inner retinal cells more time to migrate. It's almost like the gas itself is as a scaffold.
Yeah.
So how does face down influence that? Because people have changed over the years if they're doing day 1, 3, 5, 7 days of face down positioning. How does that play into the algorithm?
The short answer is we don't know.
Yeah.
I'm going to be very honest. There's so much data out there and it's more noise than it is signal. And so when you sort of take that into account, I generally sort of think about what's the size of my bubble and am I getting tamponade on the macula? So when I say face down, I almost never put patients face down. They're always in the reading position. They're sort of, because that I know I'm going to have a good sort of like contact between the bubble and the retina. And I tend to sort of say that for smaller holes, maybe I'll do just the day of surgery in terms of reading position. And then I otherwise just sort of kind of keep them upright. And when they're sleeping, ideally like them sleeping on their belly with their head turned to either side.
So how far out is this?
This is actually only about 2.5 months out of surgery. It's about 10 weeks out of surgery. And to Sarwar, to your point, when you are addressing these holes, these are chronic holes. And like one manifest of that is here you see the incomplete reconstitution of the ellipsoid zone. That can get better up to basically about a year. I would argue it's even a little longer than a year, up to about 18 months. Mm-hmm. A year is kind of what our literature supports, where these patients can have persistent recovery in vision. I've seen this patient now for years, and I think their vision is somewhere around 20/80, 2100 fluctuating.
It's nice to see that improvement with time. Patients also report, I mean, even with chronic holes, there's data out there saying even for holes, large holes that have been there for like 3, 4, 5 years, patients report subjective improvement with closing those holes. So because of that data, I've become a bit more aggressive. Whereas I see people who are like, oh yeah, I have had this hole for a long time, but they said it was chronic and it wouldn't improve. But I've actually started operating on those patients because of the gradual improvement that some of these patients get. A question for you is, your overall algorithm, when you're thinking of a hole, what are your sort of branch points, whether is it size and then tamponade agent and then obviously the technique, just doing an ILM peel versus a flap versus more advanced techniques like macular detachment or AMT. Do you have a sort of algorithm that you follow?
It's not, the algorithm can get kind of complex, and yet I think we always use simple heuristics to kind of make it digestible. And so what I would say is I sort of say, how hard of a hole is this for me to close? Let's go and take a very severe hole, a hole of macular telangiectasia type 2. It's sort of a cavitary hole. I think there's some data to support improvement in vision. There was kind of like a large multi-center study that just recently published. But the holes are very, very difficult to close because of progressive cavitation. So those are holes where I'm basically, no matter what the size of the hole is, I'm going to try and flap over ILM. And I'm going to try and address outer retinal dissection in a hole, even if it's like a 150 micron hole. Essentially, I want maximal sort of like apposition of the edges of the hole. And in the few that I've done 3 to date. I've now followed 2 of them long enough for them to progress back to a macular hole 4 to 5 years later. And so, but in that window of time, all 3 of those patients to date have said, I'm very happy for the visual improvement gains, even if they were not sustained. So I think it depends on how severe of a hole it is. And I sort of always like to sort of conceptually break it down with that simple heuristics, inner retina and outer retina. And do I think I need to address vector forces at both of those planes, or maybe just one?
I think that's what's so wonderful about our field. It's not an algorithm, right? Yeah. There is so much variables here, and each case should be taken in a unique manner. And we have a lot of different tools, and it's about applying them in the right circumstance.
Yeah. Yes, absolutely.
Well, thank you so much. This has been an incredible conversation. I feel like I learned a ton, as always, when I chatting with you about retina. And we're really excited we were able to do this in person at this meeting. We really thank Bryn Mawr Communications for helping us with this space. We're looking forward to doing more in-person podcasts in the future. And so thank you for your time.
Yeah, thanks for having me on the podcast. Really appreciate it.
Yeah, it's been great.
All right. Thanks so much. Great.